Science Liaison for AstraZeneca based in Accra, Ghana. I'm grateful that we could all join to continue this lung series, basically, of focusing on lung cancer. I have the singular honor of introducing the chairperson today, who gave us the rationale for the meeting. So she's in the person of Prof. Jane Efriye-Mensah. She's a highly respected consultant pulmonologist and associate professor of respiratory and internal medicine based at Kolebu Teaching Hospital. She has built a strong clinical and academic reputation, particularly in lung disease, especially in lung cancer. She is active, or she has been very active in capacity building and supervises residents and medical students and participates in bedside teaching with the University of Ghana Medical School. It's an honor to have her here today to share her expertise and chair the session or moderate the session on our behalf. So without spending too much time, I will hand over to Prof. Efriye-Mensah, and then she'll kick off the session. Thank you. Hi, Prof. You're muted. I think you can start.
All right. So let me say a good afternoon to all of us on this call. I hope I can be heard well.
Yes, please, Prof. We can hear you.
All right. So as always, I am excited about this meeting because I think that it meets a great need of ours, which has always been improving early diagnosis of our patients with lung cancer. Lung cancer is one of the poorest, the cancers with the poorest prognosis, and therefore it is the leading cause of cancer mortality globally. And it is the second most commonly diagnosed cancer globally again. And it is said that Africa as a continent contributes more than 50% of the mortality, but we always don't have the numbers to show. But I would say that, unfortunately, though, lung cancer cases being diagnosed in the Kolebu Teaching Hospital is increasing, which I would want to say by proxy could mean that the number of cases we are seeing in Ghana is increasing because we only sit at the tip, which is a referral hospital, and could be a suggestion that the disease is increasing in our communities. Now, if this is what is happening, then our greatest desire, because we sit on our lung cancer MDT, and almost 100% of our cases always seem to be diagnosed in the advanced stages of the disease. And that only goes to say that it comes with a very poor prognosis. How can we change this? The desire that we have is that we should be able to pick up the disease at a very early stage. And when we do that, we can be assured of better survival rates. At this point, I would say that the only way that the lung cancer MDT that we always sit on and get very disappointed can see improvement is by coming back to our suppliers, in quotes, and that is our colleagues in the primary care setting, our colleagues in district, and even lower level hospitals, as well as the regional hospitals, who would want to see these cases and then be able to either refer or take the patients on a diagnostic pathway. The best thing that we want to do now is to equip our colleagues so that they will be able to pick the disease at a very early age. The skill set that is needed to pick this disease, provide the necessary pathway for referral so that patients are not struggling to go along the referral chain. I think that once we are able to achieve this, it is all to the benefit of our patients. And so with this need and desire in mind, we cannot but be excited about this meeting because we have seasoned radiology, interventional radiology consultants who would walk us through one of the most important investigations that we learned right from medical school, and that is the chest X-ray. How we can be able to detect these conditions early enough and be able to refer our patients onwards to places that they can have diagnosis done and follow up with management. I think this is very critical, and I'm happy to say that AstraZeneca has taken the lead in this to help us equip ourselves to enable us to pick up lung cancer or cases that may appear so, and move our patients up the diagnostic chain so that we can pick up lung cancer at a very early age and help our patients in the long run. So without wasting much time, I want to introduce our first seasoned interventional radiologist, and that is Dr. Hafi Gbadamosi Ayete. She works as a consultant at the radiology department in Kolebu Teaching Hospital and is the head of the unit or department. She has several years of experience in diagnostic radiology and has been of a tremendous help to the whole chain of lung cancer MDT and then our education as far as imaging is concerned. She has a lot of experience, and I'm happy to introduce Dr. Hafi Gbadamosi Ayete to us to take us for the first session of the talk. Thank you, and with this, let me welcome Dr. Hafi. Hafi, you're welcome.
Thank you so much, Prof. Efe.
The floor is yours.
Thank you. I'm really grateful for this opportunity to give this talk. I appreciate the fact that this is a specially curated meeting for non-oncologists. So we'll try to make it as relevant as possible. So my task is to talk about basic imaging in lung cancer. And so that's what I hope to achieve today. First of all, I have no financial disclosures. And this is a disclaimer from AstraZeneca that's basically just telling us that this is for educational purposes only and does not replace independent professional judgment. And obviously, my opinions are not representative of what it's not theirs. And they also do not endorse or approve or assume any responsibility for the content I'm presenting today. So that's for your attention. So my objectives really will be in threefold. I hope to basically introduce the relevant imaging modalities that we should consider when we are dealing with lung cancer. And in doing that, I'll dive a little bit into the basic principles or basic fundamentals of chest radiography in particular, because many of us outside the teaching hospitals would start with chest radiographs. So as much as I can, I'd hope to make us comfortable with the chest radiograph. And we'll also look at some of the features of lung malignancy on chest radiography and also CT scans. So when it comes to imaging, we usually will start off with chest X-ray. That's usually the baseline imaging that many of us use. I mean, actually all over the world, we'll typically start with a chest radiograph. So in as much as we sometimes feel that it has a low sensitivity and a low specificity, it's still quite a very useful baseline tool. Following that, computer tomography becomes, very important. It's a gold standard when we are diagnosing lung cancer and characterizing it fully, determining the extent of disease, etc. We can also do PET CT scan that also has far-reaching abilities for the entirety of the patient, being able to determine the extent of metastasis. A lot of the time, lung cancer goes to the brain. So in certain institutions, they have protocols that always include brain imaging at the beginning of the patient's management. So that could be in the form of a brain MRI, which is more sensitive and can pick up more minute metastasis, or a head CT scan. So I'll start off with chest radiographs, and like I said, it's usually the first imaging modality that is performed for our patients during the initial workup for lung cancer, or even as a workup for any other lung conditions, because indeed sometimes lung cancer is found incidentally, and we use it a lot because of its widespread availability. It's probably the most prominent imaging modality in many private centers, many regional and district centers all over the country. So it's low cost, and so that makes it very affordable for our population. And when we find a lesion that we deem suspicious on chest radiography, it's important that we follow up with a more detailed imaging modality so that we can determine, sometimes we cannot conclude on a chest radiograph. So a CT scan will afford us the opportunity to appreciate more detail that could point us in the direction of a lung cancer, a definite diagnosis of a lung cancer. So with CT scan, it's also very useful in making the initial diagnosis. It helps with making a complete staging diagnosis. When patient starts treatment, you usually will do your follow-up treatment assessment using CT scan. And if the patient needs radiotherapy, there needs to be a planning CT scan done. And so obviously that would also use CT. And in recent times, lung cancer screening has become even topical in our part of the world. And this is usually done for specific groups of people who we think are at risk of developing lung cancer. The smokers, we know that smoking is directly related to the development of lung cancer. For such group of people, there are, pathways to screen them, follow up possible tiny nodules to determine if they're malignant, and allow us to intervene. That is also done using CT scan, particularly low dose CT scan. So we're going to dive in quickly because we don't have a lot of time. So we are going to deal with the important issues quickly. So when you're looking at your chest radiograph, it's important that even before you jump into making a diagnosis, you do a quality assessment check. You'd be surprised that sometimes what you actually think is a pathology could be nothing, could just be as a result of the fact that there were technical limitations to the X-ray that was acquired. So it's very important that I take you through these three main technical factors. And because if they are not done right, you could either overcall something that is actually normal, or you could miss something that could be hidden as a result of the fact that the X-ray wasn't done right. So these are the three main things I'm going to talk about. So that's the presence of rotation, inspiration, and exposure factors. Exposure factors is actually got to do with the machine, and it's got to do with the amount of X-ray radiation that is going into the patient. So we start off with rotation. Typically, when you're doing an X-ray, we expect that, so the X-ray is acquired because we have our X-ray beams passing through the patient's body. And right after passing through the patient's body, it comes to deposit on the image receptor or the cassette. And that is usually positioned very close to the chest wall of the patient. So when you have any forms of malalignment of your patient, if you have a situations where the shoulders are not aligned in a straight line, and you have one shoulder being a bit more posterior or a bit more anterior than the other, you have something that we call rotation. You have a rotated fin. So that would mean that one part of the chest will be closer to the X-ray beams than the other part. And usually we are able to determine that using certain landmarks. So when you take your chest radiograph and look in the midpoint of the radiograph, you'd find some rounded teardrop-like structures that are bony, and they represent the spinous processes of the vertebral bodies, and they should mark the central point of the X-ray. And so that's the first landmark we use. The second landmark would be the medial borders of the clavicle. So this is the right clavicle, and this represents the medial border, and this is the left clavicle. So usually if you measure, you can, just try to imagine a distance between this clavicle and that clavicle, and this clavicle and that clavicle. In your ideal chest radiograph, that distance should be approximately equal. Or, sometimes you allow room for a little bit of asymmetry. So when you have that, when you look at your X-ray and you think that, it's done right, then, you know that we don't have rotation. But then when you have a significantly widened distance on one side, then there's usually rotation to the side where the distance is longer. So that has implications for assessing your mediastinal structures. If there's rotation, it means that your mediastinum is going to be affected. And first of all, we will not be able to really evaluate the mediastinal structures confidently. We will not be able to adequately tell if the heart is enlarged to begin with. We will not be able to be confidently comment on the hilar structures. Do we have lymph nodes? Is the hilar region looking abnormal because of the rotation or not? So like I said, there are implications. So there's another image of a patient who is rotated, and you can tell straight away that the distance between the spinous process and this medial border is much shorter than this distance. And I'm sure you can appreciate the fact that even though we are dealing with the same patient, first of all, the cardiac width looks bigger. So I'll take you back to this, and it looks smaller. It's a normal cardiothoracic ratio of 47%. The guide is usually 50%. And in this case, because of the rotation, we actually have it measuring more than normal. And it will also affect the hilar vessels. So we are talking about the presence of lymph nodes, which could be relevant in somebody with lung cancer. So this is also, this is quite important. So the second thing we talk about is inspiration. So the lungs are air-filled structures. And, usually when we acquire a chest radiograph, the instruction that we give our patients is that you take in a deep breath, and that is to expand the lung fully, open up all the air spaces. And at the height of inspiration, we will take our image, we will make our exposure. So the reasoning behind that, and I would use these balloons just to illustrate that point, is that, when you have a balloon with inscriptions on it, you have this one where the balloon is completely collapsed, you have one which is partially, blown up, and you have this third one that is fully expanded. So with this one, there are actually some inscriptions on it, the yellow one, but you can hardly see it because it's completely collapsed, and it's sort of obscuring the full volume, the full size of the balloon. Second one, it's partially blown up, so you get to see some of the inscriptions, but not all. And finally, this one, full inspiration, and so the soda inscription is clear. So it's literally the same with the lung. If you don't blow it up fully, you would have areas of microatelectasis, and they could look like disease. And so you may think that you see a lung, a lung tumor in somebody whose lung is not adequately, blown up. They don't do it right. And so we could misdiagnose the patient. So these are things that you could actually do within, a few seconds of looking at your x-ray. You don't have to take, 3 minutes to do that. It's something that you practice, and over time, it just comes naturally to you. As soon as you're confronted with your x-ray, you scan, is there rotation? Is inspiration adequate? How do we check for inspiration? So, okay, so I think I will use this image. So basically with inspiration, what we do is that we try to count the ribs, and in a fully inspirated or in a fully blown up lung, you want to be able to count, objectively count a certain number of ribs. So you could actually use the anterior ribs. You notice that on a PA radiograph, the anterior ribs sort of slant medially like that. So these represent the anterior ribs. The posterior ribs are a bit more horizontal when you compare to the anterior ribs. So you could decide on, you could choose to use the anterior ribs. And so you're expecting to count between 5 and 6. And when you can count between 5 and 6, then, it means that your patient's x-ray showed adequate inspiration. So this is the first anterior rib, second, third, fourth, fifth. So usually you do the count on the right side and you end at the midpoint of the right hemidiaphragm. So we'll say that this shows adequate inspiration. Okay. So so we move on to, unfortunately, I think, yes, so we move on to the third technical factor, and that is the degree of exposure, the degree of penetration, which is the alternative name you could use. And that is really a function of the X-ray machine. So it actually depends on some of the technical factors that are used for that particular X-ray beam coming into the patient. So we select the X-ray beam based on the patient's body habitus. Are we dealing with a very slim patient, or are we dealing with a very big patient, or an average size patient? So if the patient is very big, it means we need an X-ray beam that's going to have more energy, for example. So if that decision is not done right, and the radiographer or whoever technical person chooses an X-ray beam that's a bit lower than the body size, you end up having a situation where the final image is not ideal. So I'll show you an ideal image, and then I'll show you the extremes that you should look out for and probably request for a repeat radiograph. So there's a normal PHS radiograph, and this is the hard shadow in the middle. And typically you expect to be able to see the vertebral bodies through the hard shadow. So, you just want to be able to have a visual of the thoracic spine through the hard shadow. You don't exactly want to see all the detail of the bone, but you should be able to just see, barely see it, as we typically would say. And, when you are able to see the vertebra through the hard shadow, another thing you'll be able to see is some of these lung markings, because indeed there's actually lung behind the heart. So it allows us to be able to see the retrocardiac space. So you should look through the heart all the time when you have a chest radiograph, because there's significant lung behind, and it could harbor tumor or any other pathology. So having an adequately exposed radiograph will also allow you to be able to see all these areas as well. So this is an ideal radiograph. Exposure is adequate. This patient had overexposure. So it means the X-ray beam was too much for this patient, and so we ended up having the lung fields being too dark. And when the lung fields are too dark, we are going to miss quite a number of pathologies. You could actually miss some nodules here. It would be, difficult to appreciate. It's generally not something you should be commenting on. You could, still push through and try to report it, but then we could miss a lot of things and put our patients in trouble. So this is another situation when you have underexposure. And so what I talked about earlier, the fact that you should be able to see the thoracic spine through the heart, we are completely missing that. We cannot see the lung tissue that is behind the heart. So meaning that, we could have a whole house sitting behind this heart shadow and we wouldn't know. So you should not go ahead with this radiograph. It would be it'll be a dangerous thing to do for your patient who need a repeat, or if, patient is too sick for a repeat, you may want to do, a CT scan. So when we have an X-ray, how do we go about reviewing it? What are some of the things you need to, go through to be able to conclude that you have adequately reviewed the X-ray? Okay, so there are various models you can use, but what is most important is the fact that you should always be systematic. So being systematic means that over time you would learn those habits and they'll stick with you, and all the time you look at, you're going to review your X-rays in a very predictable manner, and you're most likely not going to miss certain things. Otherwise, you realize that typically we look at an X-ray in a very haphazard manner. And, when we are lucky, we find the pathology, but we are not always deliberate about the way we go about it. So having a system-based approach, having a pattern or systematic way of doing it is very useful. So there are all sorts of models. So this is the ABCDEF one you could use, where A stands for the airway, and that would include looking. So we can start with the airway. So you can look at the trachea. The trachea is this low or lucent area. Okay, so this tubular lucent area in the midline. So we expect that the trachea is usually in the midline, and then you can see the point at which it bifurcates into the right and left main bronchus. And so you could actually look for, any area that is not like the trachea, something that is more of a soft tissue like this. So you could look for any intraluminal lesion, you could look for any abnormal narrowing, or, any pathologies related to the trachea. B represents breathing, and that is, focused on the lung, the pulmonary vessels, the pleural space. So that brings us to this whole area of lung tissue. So it's bilateral, so you need to look at it carefully. And we'll talk about even looking at the approach to looking at the lung parenchyma. So you could also look at the vessels, which I'll touch on again, but they tend to be this tubular structures. So this linear or line-like abnormalities, that sometimes we call pathologies, but basically they're part of the normal lung anatomy. And they usually start from the central hilar region. And so they sort of emanate and fan out into the lung parenchyma, and they have a distinct tapering appearance. Okay, so you don't need to call them pathology. And over time, once you take notice of them, you realize that they've always been there all along. Okay, so this is not something to be, confused about. So C is the circulation, and that includes the cardiomediastinal contour. So the heart contour is as we see it. And, the heart contour is such that you have more on the left side of the midline than the right side. So these are some of the normal radiological anatomy. And the superior contour of the mediastinum is actually slimmer than the inferior part. And on the right, for instance, the tracheal wall and whatever soft tissue is adjacent to the tracheal wall just fill up a small space. So it's a very thin area. Normally, this should just span a very thin area. We typically call it the paratracheal stripe, and it's very slim. So when you have lymph nodes occurring in that region, it would become, a wider abnormality. So C is the diaphragm and below. So yes, you need to look at the diaphragm. It usually should be sharp. It should have a sharp interface with the lung sitting on it. And of course, when you look at the diaphragm, you should look at the angle. So the angle between, the diaphragm and the chest wall is the costophrenic angle, and it should be sharp. Okay, and we also have the cardiophrenic angle at this point, and it should also be sharp. When they fill up, then usually it's as the result of fluid or maybe some pleural thickening in the early phase. And so E represents the extra, the external structures. So that includes the bones, the ribs, spine, the scapulae. So everything on the film really is your problem. So you don't just look at the lungs and, and forget about the rest of the film. Okay, so all of it really has all the information that is relevant to the patient. So we need to scan through all of these regions before we close the chapter on the patient's radiograph. So foreign materials could also be present sometimes. So this image, is just showing us the outline of the trachea and then the bifurcation on the right side. So this is just showing us a normal lung, and again, showing us all the various things I talked about earlier, the trachea, bifurcation, the heart, the contours of the heart, which should always be sharp because of the interface with the lung. It always gives it a sharp outline. So when you lose the sharp outline, it probably means that there's a problem in the lung that is sitting next to the heart. And we talked about the paratracheal stripe, which should be small, and your approach should, you could use the ABCDEF approach when you are reviewing your radiographs. So this is an example of a foreign body. This patient had a pacemaker, and the pacemaker is usually put in the anterior chest wall in a subcutaneous location, and so it will project on the lung. So this is actually just talking about or bringing to the fore some of the limitations of an X-ray. Superimposition of tissue is one of the things that we should always have at the back of our minds. If you have something on the chest wall, it could project on the lung. So sometimes the patient has a chest wall mass and that whole lung looks, opacified. So you need to remember that because it's a chest X-ray, which is, a two-dimensional picture, it's really just projected the whole patient from anterior to posterior on one film. So sometimes what you see and think is within the lung is actually, on the patient's chest wall, anteriorly or posteriorly. And sometimes doing a lateral radiograph can help. Other times, you may have to do a CT scan. So like I said earlier, systematic approach is key. You could also do an inside-outside approach. So you could start from the heart, look at the mediastinum and the hilum, look at the lungs, and then look at the bones. Or you could start from outside and come inside. There's no, perfect approach. You just build your approach over time, and then you stick to it, and over time you become, perfect at it. So once you've done all of that, and you focus on the problem, you then, try to characterize the problem. What do you think it is? What does it look like? What does it mimic? And, once, you've done that, you can probably start to, think of a diagnosis. Sometimes it's difficult to settle on a diagnosis, so you may give a number of differential diagnoses. So just bringing us back to the lung and, the way and manner in which we could approach evaluating the lung. So you hear me talk about patterns a lot because it's really useful. And so this pattern really is talking about dividing the lung into three main, halves. So dividing each lung into three main halves, almost equal halves. So that will give you an upper zone, a middle zone, and a lower zone. I think this is easier than attempting to use the lung lobes. So the lung has lobes, and that comes about because of the divisions formed by the fissures. So on the right lung, we have two fissures, and that divides the lung into three lobes, so upper, middle, and lower lobe, whereas the left has two main lobes, which is divided or brought about by the solitary fissure on that side. It's not always easy to talk about the lobes on a frontal chest radiograph like this, because you may think that because you're in the upper part of the lung, you are looking at the upper lobe, but it's not entirely so, because the lobes sort of overlap on each other, and you may actually be in the parts of the apical part of the lower lobe, even though you are up in this section. So I think the safe bet for many of us is to divide the lung into lobes, so that when you are describing the pathology, you would localize it to the specific lobes that you've assigned. So basically, you try to look for asymmetry when you're looking for pathology. Many people seem to prefer the pattern of looking down that same side. You look at it fully, carefully, scan through it, and then you look at the other side also, scan through it fully before you compare the both sides. Because sometimes in our attempt to do everything at once, we end up leaving a lot of blind areas. So it's useful to just, scan down one lung, scan down the other lung, and then compare both sides at the end. Then you're sure you don't see any asymmetry. So because majority of the times for all of us, our lungs are symmetrical, okay? The density of one lung should be similar to the contralateral side. So if you see some slight increase or any abnormal increase, you should flag it and try to figure it out. So there are hidden areas in the lung. They are hidden because we tend to forget to look at them. And the main ones include the apical lung, usually above the clavicle, the hilar region, and the retrocardiac, and also the the area behind the liver. So this is the liver shadow. You actually have some lung tissue there. And I brought this image to just illustrate the point. This is the liver, but you also have the lower parts of the lower lobes, sort of, in a much lower position than the anterior part of the lung. So that would mean that you'd still have lung behind the liver shadow. And so we need to look in that region to look for any lung pathology. And you can actually see some lung markings running posterior to it. So this is a classic example of, one such, pathology that was ignored in a hidden area. And here on the chest radiograph, I think it's probably easy for all of us now. This is in hindsight. This was a lung mass that had been growing over months. And eventually when they found it and went back to the previous images, it had been there all along. And, they had failed to look at that area. And this is what it looked like on a CT, very ugly looking mass, which was malignant and had to be dealt with. So yes, just to recap the important anatomy, So yet lung parenchyma, this is the hilar region. The hilar region is made up of main pulmonary arteries, and to some extent the veins as well. But you see how they taper out into the lung parenchyma, and the distal ends are smaller than the more central portions. And these are the costophrenic angles. They should be sharp and should not contain any opacities. It should all be lucent like the rest of the lung. And usually when they're opacified, it's due to fluid. And above the angle is the area that we call the recesses. And so basically this is how it should look like. These are the lung markings made up by the pulmonary arteries. And like I said, they taper as you go down out to the periphery. And typically the upper ones are a bit smaller than the lower ones because of the effects of gravity. So these are just things that you keep at the back of your mind. So they can mimic tumors sometimes. Sometimes people aren't sure what they are. So we just wanted to get that out of the way. So now let's talk about pathology. We oriented ourselves in terms of their normal anatomy, which is extremely important. And opacity is really when you have increased lung density. And that's really sort of a surrogate marker of the reduction in the degree of aeration of the lung. And densities are caused by many things. And, it could include fluid, exudates, hemorrhage, and cells. So today we're actually going to focus on tumors. So an opacity is actually quite non-specific. It could represent many things, as I've noted here. It could represent a pneumonia, it could represent a tumor, it could represent pulmonary edema. So history is actually very, very important. Duration of symptoms is also very, very important. So S-phase opacification, which is what I've described, is actually equivalent to like consolidation. So, I mean, back in the day, consolidation was considered a pneumonia, but it's actually just a non-specific term for, an opacity in the lung. So what are the suspicious chest X-ray findings that should make us worry that, what we are looking at could be a lung cancer? So lung cancers could present in various ways. You could have those presenting in a more central location. So the small cells, squamous cells tend to be more central, and the peripheral ones tend to be more of the large cell and then the adenocarcinomas, but it doesn't always follow that pattern. The nodules are the small, well-defined opacities, which are usually less than 3 centimeters. And the masses are those that are greater than 3 centimeters and are obviously larger. So these are all things that could represent tumors. And a bulky hilar region could also be indicative of lymph nodes or even a primary mass. And that could result in obstruction of the airway. And so you could have, in addition, a collapsed, lobe of the lung. These obstructed airways could also give rise to post-obstructive pneumonias in the affected side of the lung. You could have multiple nodules or single nodules. You could have what we think is a non-resolving pneumonia, which would actually be a malignancy. And pleural effusions could be the first sign of a pneumonia, or masses with cavitation could also represent some lung cancers, especially the squamous cell ones. So this is like a normal X-ray with some schematic annotations. So this lesion with sort of rounded borders is representative of a mass. So usually the mass have convex rounded borders. They're well defined. This is the bulky hilar, so it could represent a hilar lymph node or a hilar mass. This represents a pleural effusion. This is a small nodule less than 3 cm. This was a pneumonia, and this was due to collapse of a segment of the lung. And usually collapse comes with, very unique features that make us think that, what we are dealing with is collapse. So for example, the fissures on that side will usually be retracted towards the side of collapse. So, so we're going to look at some chest X-ray findings which were indicative of lung cancer. So this is a well-defined rounded lesion in the left middle lung zone. Now we know all the terminology to use, and it has a lucent area within it. This is what we'll call a cavitatory region. And so it means, so basically this is the wall of the cavitatory mass, and this wall is considered very, very thick. So when you have a thick wall cavitatory lesion, straight away you start to think malignancy. And it would differ from the more benign cavitatory lesions like abscesses because they tend to have smaller walls. Here we literally have a mass because the wall is quite thick and you have a cavitated area. So I'm just noting that there's no evidence of effusion because the costophrenic angles are quite sharp. This is another chest radiograph of a patient who has a rounded, well-defined mass in the upper lung zone. And so you can see that the inferior borders are well formed and they're rounded. So we are already thinking mass at the back of our minds. And when you try to look at the ribs, you realize that this part of the rib is destroyed. So it's actually increasing our sensitivity for malignancy here, because we know that malignant lesions tend to be aggressive and could destroy nearby bones, as we had in this stage, in this case. This is another end of the spectrum where we have what looks like an opacity, what we'll call a consolidation, because it's not entirely homogeneous like what we saw earlier. I'll just take us back just to give us that view again. So here it's more of an inhomogeneous opacification. And, for all intents and purposes, we would call this a pneumonia. And we wouldn't be wrong with the appropriate clinical history. If this patient came with a cough, chest pain, fever, duration of three days, you would be perfectly right to call this a pneumonia. However, in this patient, they did not respond to all the treatment for pneumonia. And so they started to think that this was a chronic consolidation. And of course, malignancy also became, higher up on the list, and it ended up being a malignant lung lesion. So these are actually the ones that cause the most problems because they look like your pneumonia. But when you think about the patient's age, older, if the patient doesn't have constitutional symptoms that suggest a pneumonia, we should consider a chronic, something more chronic or something malignant, as it turned out in this patient. Here we have the patient presenting with a homogeneous opacification of the middle and lower zones. We clearly cannot see the costophrenic angles. So whenever we lose the costophrenic and cardiophrenic angles, we should think about fluid in the, I hope you can hear me.
Yes, we can. I think we have about 5 minutes more to wrap up.
Okay, all right. Yes, I've overdone my time. So I think that I would move to the chest CT. So basically, chest CT has many advantages. It gives us high quality images. It's, however, expensive, and you have to deal with the radiation dose, which is much higher than an X-ray. But it gives us so much detail that we will not see on an X-ray. It allows us to modify the images that we see, so we can, we can modify and tweak and focus on the lung to have a lung window, or look at the mediastinum to look at the mediastinum window. So this is a lung window. And another thing that we get from a CT that we don't get from an X-ray is that we can see smaller segments of the lung. And so that means that you can localize tumors to smaller segments. And that would make it easy or amenable to, resection by the surgeons. If we know that the tumor is limited to a segment, they can remove that segment without taking out the whole lung and probably increase the outcomes for our patients. So this is the mediastinal window, which focuses on the mediastinal structures. And this here, I think, was just focused on the lobes as well. So what is the role of CT here? It helps to, to help us characterize further whatever we see on X-rays. So that is, I think, the bulk of what we do. We see something on an X-ray and we escalate to a CT to help us determine what is going on. Is it truly a malignant lesion, so that we can make that diagnosis of primary lung malignancy? And also, we are also able to very clearly determine if the tumor has responded to treatment or if it's still progressing. And also, like I said earlier, a useful tool for screening. So on CT, we are going to look at the location of the lesion, just like on X-ray, but with additional detail. We can dive in, talk about, more of the characteristics of the tumor, also talk about staging. So are there lymph nodes? Is there invasion of the pleura? Is there invasion of the tumor? Is there distant metastasis? So CT affords us all those, those things that we will not get on the CT. So on, there's some additional, the nature of the opacities can be further highlighted on a CT. So, not all opacity is a consolidation. All right. So here we have an opacity which is fairly, not dense enough. It's sort of like a partial filling of the lung or partial opacity. I say it's partial because you can still see these brighter structures which represent the lung marking and the pulmonary vessels. You can still see them within that area of the lung. This is obviously a nodal, it's very dense. And I would compare that to another image where you have what looks like opacities, but it's not, a very dense opacity that obscures the background structures like the pulmonary artery. So we call this ground glass opacification, and we call the denser one consolidation. They are both associated with lung malignancies, and they could both be seen on imaging. So this is a patient who had what looked like an opacity or consolidation in the lung. You see areas of ground glass opacification, which are not as dense as this, the other portions which are denser. And this patient ended up having a pneumonic type adenocarcinomas. As I was saying, is the pneumonia ones that end up causing all the trouble, because everybody thinks that they are pneumonias, and then we treat them for a whole year. Sometimes we treat them for TB, and then you can imagine the amount of time we lose. This is a nodal, it's less than 3 millimeters, but look at the margins. The margins are lobulated, and the margins are also quite irregular, what we call spiculations. This is a very classic malignant feature. And so when we see that, we are worried. So basically, for the nodules, when we have margins like this, we consider them red flags because they are suspicious for malignancies. This is another similar nodule with spiculated margins. It involved the pleura, and it also destroyed the adjacent bone. So it had implications for the staging. This is a patient who had a more advanced tumor, and the whole lung was filled with dense consolidation. There was involvement of the pleura, and there was also involvement of the mediastinal structures. So it was easy to make the staging diagnosis for the patient. These are images of for both patients, adenocarcinomas. In one, it was fully ground glass. In this, you had a mixture of a solid area and a ground glass picture. So these were considered adenocarcinomas. And yes, I wanted to show this. This is a mass, but it has a large cavity within it. And it's a central mass, which is invading the mediastinal structures. And this was a malignant tumor found to be squamous cell carcinoma. And look at the thickness of the wall. And then that was very suggestive of a malignancy rather than TB, which will tend to have smaller, a thinner wall. So so this is just putting side by side a chest radiograph and then the CT scan, and just making us appreciate the additional information the CT presents to us. We get to see the relationship with other structures so much better on the CT, relationship to the bone, relationship to the vessels in the thorax. This is the trachea, the esophagus would be somewhere here. So it gives us additional information for the staging. So here, lymph nodal classification is very important for lung cancer staging. So it's much easier to do that on the CT. And so we get to see their pre-tracheal lymph nodes present, pre-vascular lymph nodes, and they all look suspicious by CT classification. And yes, in the interest of time, I'm just skipping through some of the slides. This was a CT-guided biopsy that was being done to acquire tissue, because ultimately we always need tissue to make a definitive diagnosis so that the patient can have the needed treatment. So this was a CT-guided biopsy, which we are able to do, luckily, so we can get samples for our patients. And this is an example of a screening of a patient who had a very small nodule that was followed over time. And between, over the span of a few months, it was determined to have increased in size. So they were worried, and so they went ahead and removed the nodule and was found to be malignant. So screening is one of those things we don't do now, but definitely one of the areas we need to start considering. These are PET scans, and PET scans are more of, a complete body scan or screening tool that can help us localize the presence of widespread metastatic disease, and also can tell us if a tumor that has been treated still shows signs of active disease. Because sometimes just using the regular CT and MRI, you may have a lesion that following treatment is still present, but may not necessarily harbor the disease, may just be post-treatment changes. And on the PET scan, when that area continues to light up like this or this, you can safely say that, well, there's still tumor, but if there's no evidence of tumor avidity, you could say that, well, it is not suggestive of, active disease. So like I said earlier, the brain, lung tumors like to go to the brain a lot. So you could also consider brain imaging. And, we can tailor our protocols to include brain CTs or brain MRI as appropriate. So thank you for letting me steal additional time. I think I'll end here. These are my references. Thank you so much for listening.
Oh, thank you so much, Dr. Hafi, for this elaborate lecture. In fact, this has been very educative, even for us pulmonologists, and it is more than I can even try to grade. I am happy that the achieved, the objective that we want or we set out has been achieved with this lecture. Then our colleagues in the primary care can identify lesions earlier and move the patients up so that our patients can benefit from early diagnosis and obtain cure in most cases when they are picked up early. Thank you very much, Dr. Hafi. We are welcoming questions, but we would like you to type them in your in the chat box so that after the second lecture, we would have time to go through the questions. Thank you very much. And without wasting much time, I would like to invite another seasoned interventional radiologist, Dr. Yao Boateng Mensah, who is also at the Department of Medicine, at the Department of Radiology, Collingwood Teaching Hospital. Pardon my medicine bias. And he is going to take us through practical sessions on chest imaging and help us, equip us more to be able to pick up these lesions. Very soon we'll come knocking on your doors with screening eligibility and criteria for patients whom may qualify, and therefore we'll be happy for you to walk through with us as Dr. Yao Boateng Mensah takes us through the next session. Doc, you are welcome. Prof. Yaubi.
Yeah, so thank you very much.
Yes, Professor Yao Mensah, you are welcome. I want to see your picture.
In a bit, you'll see my face very soon. Please, are you seeing my screen?
Yes, we are, but not in the presentation mode.
Yeah, in a bit.
Okay. Professor Yaubi, the floor is yours.
Thank you very much.
Okay.
So I want to use this opportunity to thank.
Please, we can't see your picture.
Sorry. You can see my
Thank you.
picture now.
Yes, I can even see your glasses.
Okay, that's good. Thank you. So before I go on, I was trying to do something which I don't know if it will. Let me see if I want to share a link. I don't know if it will work. We'll try. If it works, fine. So let me stop sharing my screen briefly, and then I'll share. I want to share a link. I've tried to design something like a Google form, so that people will attempt to participate more or less, in what we are doing. So in a minute, Julia, I've sent you some invitation. Did you receive it?
Yes, please, Prof. I have.
You have. Okay. So basically, what we'll do is we'll go to where's my form again? So we'll go to so you go to like the results, so that when people answer, you just give me a brief this thing about, okay, maybe 20% said this, 40% said that. You get what I'm saying? Will you be asking for too much?
Yes, please, Prof.
Okay.
Give me a sec. I hope I won't be asking for too much if I do that. Madam Chair.
No, I think that will be more interactive. So we welcome that.
So I've shared the Google form link. Okay. It says me to host and panelists. Okay, so please, can you share with the rest of the people? I don't know how to share. Okay. All right. So now let me go to my screen and then let's start talking. So as my professor has said, my name is Yao Mensah. I work at University of Ghana Medical School. Okay, so this is my disclaimer, as my predecessor said, this is the disclaimer, and because I've spent so much time before, I'll just jump and use this opportunity also to thank the presenter before me, my HOD, for doing a good job. It looks like it will make mine very, very, very easy for me. So we are going to look at what our objectives are here, review a few imaging features of lung cancer, and then we'll see some images and see what we can make of those images. Okay, so I mean, she's gone through all this, so I won't bother to go there. So when it comes to lung cancer, I mean, broadly, they divide it. I mean, I have professor of pulmonology here, so if I'm wrong, she'll correct me. But broadly, we divide them into two: the non-small cell and then the small cell. Then we have a small column for the others, like lymphoma and sarcoma. Under non-small cell, you have adenocarcinoma, squamous cell, large cell. I mean, this is more like a summary. And then the small cell is small cell. Okay. So there are a few things that come into play when you are talking about, lung cancer on CT scan. And I think that Dr. Gbadamosi has done a good job there. But these are the terms that you meet on your way, when you're talking about CTs, lung cancer on CT or even on X-ray. So is it a mass? Is it a nodule, which she has told you? So a small opacity less than 3 cm, you push it towards nodule. More than 3 cm mass. Consolidation, I'll show you a picture on consolidation ground glass. Is there a cavity? The way I try to remember a cavity, and when I'm teaching my students, what I say is that, well, if you look at the lung, we see airways and we see lung parenchyma. Okay? At no point in time should the lung parenchyma be as dark as the airway. So if you have a roundish area in where you think the lung parenchyma should be, and you see that that place looks like the airway, then possibly there's a cavity. All right. So this is something to take speculation. Okay. There are times that you also see lung collapse. That may be all that you see. And then if you search further, you will see that, oh, apparently there is some tumor somewhere that is causing the collapse. If the lesion is peripheral, you may see some mucocele that is giving us, on X-ray, I mean, at times when you have some lung cancers at the apex, you may see adjacent collapse. And this gives us what we call the golden S sign, I'm sure. And then there are times that you see apical masses, okay, which may erode the ribs nearby and cause some paresis of the eyelids, okay? And we call that Pancoast tumor. You may just see pleural thickening, pleural effusion. You see some diastinoid lymph nodes along the line. And then there are times that you see SVC obstruction where the person will have enlarged vessels on the chest wall and all those things, okay? So these are some things that are worth noting, or some terms that are worth noting. Okay, the other thing that you hear in the lung cancer discussion is the lesion central, is the lesion peripheral. Okay, so if you remember, Dr. Gbadamosi mentioned some things that said, okay, these ones tend to be central, these ones tend to be peripheral. Okay, indeed, as Prof. Fiye said, I think almost all our lesions traverse the two regions. So, I mean, really, 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 I mean, maybe some years to come, it will matter to us that much. But for now, most of them traverse, both regions anyways. But it's worth noting that which one do we call peripheral and which one we call central. So Dr. Kwadamusi has already mentioned this one. When we say a consolidation, you have an opacity which obscures your lung markings. So these whitish things that you see here, they are what we call lung markings, and they represent the pulmonary vessels, okay? So if you see these ones, okay, no, if you have an opacity like this one, and you can't see these ones within the opacity, then we say there's a consolidation. In addition to that, like if you have what we call the air bronchogram, some airways that are branching in it, then you call it a consolidation, okay? If you have an opacity, but you can still see the vessels pass through, we call it ground glass opacity. Okay, so that is something that is worth noting, okay? So these are 3 ground glass opacities that we use in the lung cancer, you know, parlance, okay? So this is like a regular opacity, which we call ground glass, you know. Usually the ground glass opacities go for the adenocarcinomas, okay? So then here, we have an opacity, all right, but just at the tip of the opacity, you see something, some opacity that has the density of like the adjacent vessel. So when you have an opacity that have 2 kind of densities, you know, then you call it part solid, okay? So you have some solid components in here, and then you have this ground glass background, okay? Then this one is actually like this dense, this you call solid, but then you have some ground glass opacity in the periphery, okay? Note that the part solid is more like almost all ground glass, but then a small part of it is solid, okay? With time, this can progress and become like this one, okay? That is showing you the aggressive nature of the disease. So you need to know, if you are reading some material and they say solid, part solid, you need to know what that one stands for, okay? And then this is showing you what we say, if we mean we have speculated margins. So you have this dense structure here, and you have speculated margins, okay? Some will also use a temporal radiata, you know, something like that, okay? And then let's look at this picture here. It's a little interesting, okay? So you will see that we have 2 shades. There's this closer, this is the airway. So there's one part that is closer to the airway, which is more like having 2 shades, like dark and then some brightness around it. And then you have the peripheral one, which is fairly uniform, okay, fairly uniform gray. Okay, so basically what is happening is that this is where the tumor is. And by virtue of its location, it is obstructing the airway, and therefore we are having a peripheral lung collapse. All right, so for those of us who do biopsy, for instance, what it means is that you may have to traverse the collapse and come to where there is the mass. Otherwise, they'll tell you have biopsied lung tissue. So you just need to pay attention to some of these things. All right. Then these are people's suggestions, okay? But they are not always. In fact, for the MDT images, I decided to look through the MDT images we've done since, I think, May last year. And none of them, not even one of them, followed this pattern. Okay? I mean, okay, well, all this. Okay, so let's put it this way. Let me be careful what I say. So, like, for instance, for number 2, that one, it follows. I agree. For number 3, it follows. Yes. But I was talking about 4, 5, and 6. None of them follows. Okay. So number 1 says that if you have a speculated margin, you know, you are likely to have some lymph node involvement, some vascular involvement, and also, especially if the speculations are thick, then your prognosis is guarded. All right. So I've already said consolidation with air bronchogram or ground glass opacity will go for adenocarcinoma. And then you see cavitations in squamous cell, quite about 80% may have cavitations. All right, because they have necrosis. Okay, so let's just jump. Okay, so Julia, please, so did you get my link?
Yes, please, Prof.
You got my link. Okay, so like I said, we'll go to where the results, you will just look at the results. So people, if you go, you see case 1 there. Okay, they are very basic questions. Okay, very, very basic questions. Let me also pull mine by the side and then, very basic questions. So just use the link and then answer. Tell me what you think, okay? Hey, nobody has responded. Or Julia, I haven't shared with them. Has it been shared with the rest of the group?
I have, Prof.
Oh, I'm not seeing any response. Okay. People don't want, but this one they are very basic questions. Okay. So the first question that was there was that, what are you seeing? Are you seeing consolidation? Are you seeing a mass? Okay. Are you seeing a mass? And then the other thing is that what you are seeing, is it central or peripheral? I'm not seeing the responses I thought I would get. Okay, anyways. So let me go on. Because just so far, it's just one person that has responded. I don't know. Julia, am I right? Okay, I'm seeing 4. Okay. So, I mean, Julia, okay. Okay, 6. Okay, good. So somebody said there's consolidation.
They're still responding. So
oh, yeah.
they're still responding. We got 6.
Okay. We have 6, Okay. All right, that's fine. So a lot of people are saying it's a mass. It's not consolidation. That is good. And then a lot of people are also agreeing that it's central. Okay. So usually, just from what we said, usually central, we are looking at squamous cell and then small cell. Okay. Central, you're looking at squamous cell and small cell. So, I mean, ideally, if we try to guess a histological diagnosis, then we may be thinking either squamous cell or small cell. Okay. I don't know, Prof. Mensa will tell me, it looks like all the images that we reviewed with the histology, there's no, what do you call it? Small cell, I don't know if I'm right. Have you seen a small cell now in our list? Anyways, so this one ended up, so you can see what we are looking at here is this mass that is here, and on this, you can see this one here. Okay, and then in addition, you can see met to adjacent lung parenchyma. Okay, so this one, when we did the histology, biopsy and histology, it came out as an adenocarcinoma. Okay, and we've already said that, I mean, at times, most times from what we have already read from what Dr. Badamosi said, and then what I also showed you briefly, then you may be dealing with, you would rather say a small cell or squamous cell. But interestingly, this one ended up being an adenoma. That's my basis for saying that they don't follow, So it said a mucinous adenoma. Okay, so quickly, let's go to this one, case 2. All right, quick, please just give me some. So if you look, you see what it says, the questions. Okay, quickly, second question. Let's see what people are saying. I hope they will answer for me. Nobody is answering. Okay.
Are you sure they are not answering?
Okay. Now I can see. Okay. I can see. But 2 people, okay, homogeneous opacity and meniscus, which is right. Okay. So we can see homogeneous opacity here. Okay. And then you can see it with a meniscus. Usually when you see this and you don't see the hemidiaphragm, then we'll be dealing with effusion. Okay. So this one came in with effusion, as has been stated, and then chest pain and difficulty in breathing. Okay, but it looks like the effusion was recurrent, So for 6 months, they may have treated something like that. So, I mean, if it's there, so they went ahead to do CT, okay? And then this is CT. So let's go to 2B. and tell me what you think it is. 2B. Okay, so let's see what is the question in 2B. 2B is, are you seeing a mass? Are you seeing consolidation? Are you seeing effusion? You can choose more than one. Let's see. Okay, 2B, we are seeing mass, we are seeing effusion. Okay, excellent. Okay, I know that if I say, where are you finding it, it will be a problem. But this is in the anterior mediastinum, okay? You see, it's anterior, or some people will say prevascular space, okay? So you can see this mass here, okay? And then this is what the effusion is. Okay, so that is excellent, excellent, excellent. So my people are working hard. Okay, fine. So
Prof.
this one,
Yalvi,
yes.
case 2A.
No, there's 2B. This is 2B.
Okay.
2A was X-ray. The A's are usually X-rays. So fine. So this one.
But did you see the mass on the X-ray? We did, isn't it?
No, they saw effusion. There was effusion. There was no mass. You couldn't see the mass.
Thank you.
It's just okay. Well, somewhere here looks a bit funny, but I mean over here.
Yeah. Thank you.
Okay. All right. So now let's see here. So here we got a mucinous a carcinoma. They say whatever. A poorly differentiated carcinoma. Okay. And they were going to do some things to help us, get better understanding. So yes, here we are, seeing the mass. Okay. Let's go to 3. Sorry, I'm rushing you. I don't want to be knocked out of the distance. So 3, are we seeing anything at all? Let's see what the question for 3 says. Okay, are you seeing a nodule? Are you seeing a mass? Are you seeing a cavity? Okay. Are you seeing consolidation? I think let's say nodule and mass are the same. So for this particular case, because we can't measure. So nodule, mass, are you seeing any cavity? Are you seeing consolidation? Please choose for me. Okay. So nodule, a few people have seen cavity, a few people have seen consolidation. Okay. But nodule, mass. Okay. So if you look carefully, you can actually see this, light roundish thing here. Okay. More or less, you may push it to ground glass because usually, let's say if it's even like you want to call consolidation of ground glass opacity, you may push it towards ground glass because it's very faint. Okay. All right. So okay. So here, let's go to 3B. Okay. So here you can see it better. All right. You can see it better. Okay. Now, let's see the features that we learned from Dr. Gbadamusi. So what are we saying for 3B? Is it solid, part solid, consolidation? Are you seeing speculation? Are you seeing air bronchogram? Please choose for me. We are just applying the terms we've learned from Dr. Gbadamusi. So solid, okay. Are we seeing solid and then speculation? Excellent, excellent. Okay, I didn't want to bring in zones and those things. Okay, so that it won't create problems. So yes, speculation, solid. Okay, so you can see the speculated margins. Okay, and then it is solid. Okay, we are not seeing, some faint ground glass around it and all that. So basically, that's okay. Anything okay? So here, with and then you can see, look here, you can see one nodule here too. So obviously it's malignant. We are not going to talk tuberculoma or anything like that. Okay, so this is a malignant lesion. We've seen it. Okay, so now are they both met or this is primary? All right. This woman, for a few years, had to chase a few times, but eventually apparently had the biopsy done, and it ended up being a carcinoid tumor. Okay, a carcinoid tumor. All right. So at least we can see the speculations here. This met. So this is the primary, and then we saw this one as met. Okay. All right. So please, case 4. Case 4. Let's see the questions. So case 4, I mean, I've varied it so that, okay, so where are we finding it? Upper zone, middle zone, lower zone, the abnormality, okay? And is it right or left? Just so that we know whether people are weak. Okay. So let me go and see the responses to case 4. Okay, 4A, okay. 4A, upper zone, right. Hey, almost like 100%, upper zone, right. Nobody is deviating. Okay, so yes, that's fine. So we can see this lesion here, you know, uniformly radio opaque lesion here, you know, and yes, it's in the upper zone. You can see some fullness here and here, but you know, for the elderly patients, at times you can have fat, you know, there. There's a bit of widening mediastinum here. All right, so now let's go and see what the CT says. Okay, so over here, we can, okay, so let me hear you. Let me go to question 4B before I talk. Okay, what did question 4B say? Question 4B. Okay, is it central? Is it peripheral? Will you be confident enough to say adenocarcinoma? Based on, we are just using this one based on what we have said. Those who commonly are central, those who commonly are peripheral. You get it? So adeno squamous small cell, which one would you choose? Okay, so let me look at the responses. So this is 4B. Okay, peripheral 100%. Okay, but is it, was it only choose one? You are supposed to choose the other one too, or?
Prof, I think that one you can only choose one. Yes, please.
You could only choose one. Oh, okay. So basically this one was biopsied, okay? And it was a squamous cell, okay? But what did we say? We are saying that what? Adeno is peripheral, isn't it? Squamous is central. But this one is squamous cell. You know, it was squamous cell. So, I mean, we are just learning, you know, and you know, you can see this mass here, you know, a bit of ground glass around it. And eventually when we biopsy, it was squamous cell. So let's move on to case 5. Case 5, nature of lesion, but let's jump case 5. We'll go to case 6. So this is a huge mass, okay? Huge mass. But if you look at it carefully, it looks like what I showed you initially. You can see that here, somewhere here. Let me do this and see. Okay, so you can see that somewhere here. Okay, coming here. Okay, it's a little bit more heterogeneous, okay, than this side. Than this side that I'm shading, okay? Okay, so I'm going to go off the shade, okay? But before I go off the shade, you can also see that, like I said, this side is a little bit more, you know, heterogeneous than if you look at, let's say, this side, and this side. They are a bit more uniform. Anyways, so let me just go off, sorry. Let me just go off and clear all my drawings, okay? So basically, what is happening is that this central bit is where the tumor is, and you can actually see it going into the airway. So this one, I think Prof. EMS, I even biopsied it endobronchially, okay? So you can see it going into the airway, but just as we said, this part going is fairly uniform. You can see a homogeneous, more or less opacity there, okay? Just as you can see this bit being a bit more homogeneous, okay? So then that one is due to collapse, okay? So this one So the mass is centrally and is causing peripheral collapse of the lung. Okay, so this was an adenocarcinoma anyways. This was an adenocarcinoma. Okay, but this one is neither central or peripheral, isn't it? It has jumped across, okay? So anyways, let's go to 6. Let's go to 6. 6. So what is the question for 6? So are we seeing mass? Are we seeing collapse? Are we seeing, sorry, 6, sorry, 6. Upper, lower, middle, right or left? Let's see the responses. Let's see those who are awake.
Prof, please, we can't see the pointer well, so I don't know if you could
But I'm not supposed to show pointer.
No,
The
when you're demonstrating. Yes, when you're describing.
Okay, I should use the laser. Okay.
Yes, please, that'll be awesome.
At times the laser when you are using it, advancing your slide is difficult. Okay, let's see. Let's see. Let me use laser. Okay, that's fine. Okay, so where am I? Upper. Hey, this is heterogeneous answer. Okay, so I have upper a lot, upper more than middle and lower, which is fine. Okay, which is good. And then right and left equal. Okay. All right. So here we can see some opacity here. You see, if you compare it to this side, okay, you can see that there's some opacity in this region. Okay. All right. So left upper. Okay. Now let's go. So over here, let's go to. Okay. So I jumped. I think I didn't ask questions for 6B. So over here, you can actually see this central mass. Okay. Speculated, and then we have this metastatic nodule nearby. All right. So this, you can actually see it here as well. So this ended up being an adeno. Okay. An adenocarcinoma. All right. So that is fine. Okay. So case 7. Interesting case. Now the question is, for case 7, we have just 10 cases. My time is not plenty, so, and I also don't want to bore you. Okay, which body parts show disease or have disease? Lung parenchyma, rib, mediastinum, chest wall. Okay, so where do we have disease? Let me go and see responses. Okay, 7. So I have lung parenchyma, I have rib. Okay, but it's only one person who has responded. Okay. In fact, I should have said right rib, left rib, so that I'll know whether people are guessing or not. Okay, so I have 2. Lung parenchyma. Oh, one more should add to it so that I know people are listening to me. Okay. A few more.
Prof, more people are writing in the chat lung parenchyma.
Oh, they are.
Yeah.
Oh. Okay. 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 So what are they choosing? You can say that. Let me look here. So I have chest wall. I've seen some chest wall. I've seen mediastinum. I've seen. Okay. So what are some people writing? I see lung parenchyma. Okay. I see mediastinum and parenchyma. Okay. Okay, that's fine. We are good. Okay. So here we are. This woman presents with chest wall pain or rib pain. Cute old lady, nice, pleasant woman. Chest pain, and we'll point to the site where the pain is. Unfortunately, X-ray didn't show much. So they said, okay, then let's do CT. Okay, so yes, we are seeing this one. Okay, then on the CT, we saw this. Okay. Oh, okay, primary lung. Okay. Anyways, let's go and biopsy and then characterize it. Now we biopsy What do you think it will be? Anybody wants to try and tell me what it could be? Chat. Let somebody put in the chat. Let me see. We biopsied it. Is it adeno or squamous or carcinoid or, you know, any Julia, what are they saying? Adeno, carcinoid, adeno.
No, I'm seeing squamous
right.
And then carcinoid. Some adenocarcinoma as well.
Okay. But if you can look on the chest for, you know, it means there's been some infiltration. If you compare to the left side, the right side, there's some thickening there and all that. Okay. So apparently this woman had been treated for breast cancer, you know. So this was breast cancer that was coming back, but into the lung and into the chest wall. All right. So that is something we need to also pay attention to. Okay. Let's keep going. So case 8, recurrent pleural effusion. Let me see. 8A. Question is, where do you find the abnormality? Where are you seeing abnormality? Let's see responses for 8A. Yeah, I'm not getting response. I'm not getting to go to the responses. So, hey. Okay. Nobody has responded for 8A yet. People are tired. Okay. So upper zone, right? Middle zone, right? Okay, upper zone. Okay, upper zone is shining. Okay. Okay, middle zone. Okay, so yes, so we have upper look fairly okay. I don't know. Okay, but here you can see this opacity and then like some here, this side. So basically, that is where our story is. Okay, and then we came and did CT, and you can see a bit of effusion. You can see a bit of something like thickening of the pleura. You see here. Okay, so you have your effusion and see something like thickened pleura or adjacent atelectasis and all that. Okay, you can see some here, some lymph nodes. I mean, unusual lymph nodes. You know, you can also see this is the trachea. You can see some lymph nodes here. You know, and histology, mesothelioma. All right, mesothelioma. All right, so we are seeing varied presentations. We need to think wide. We use our basics, but then, you know, and then we so that we can guess correctly. Okay, so basically, this was a mesothelioma. Okay, let's go to 9. What are the questions? So we are up to 10. So once you see 10, you know that the exam has ended. You can breathe. Okay. So we are up to 10. So here we are 9. So 9A. What are we seeing? This one, the question is not a good question. Are you seeing a nodule, a mass? Are you seeing some meniscus? Are you seeing a cavity? I didn't know how to. So anyways, so let's jump to, I mean, it's not a fair question. So let's jump to let me just, so we can see this homogeneous opacity. Okay, look at the left hemidiaphragm. Okay, so we are not seeing a hemidiaphragm here, homogeneous opacity. We are not seeing the heart margin on the right. Okay, and then we are seeing this calcified lesion somewhere. All right. So, I mean, ideally, if you ask me, okay, I'm sure I may opt for some effusion, okay? But always, you know, just to be careful, I say that, well, there could be some, you know, consolidation in as well, depending on the story they tell me. For instance, they are telling you that 1 year cough, you know, associated chest pain, weight loss, night sweats, and all that, okay? I mean, could it be TB? I would say that in our environment, not typical, you know, but it could be. So anyways, so went ahead to do CT, and then this is what came up. So let's choose one. What do you think? Small cell adeno squamous, TB, sarcoid, lymphoma. Choose one. 9B. Choose one for me. Let me go to my responses and see. Adeno. Okay, lymphoma has come in. Okay. Yes. Any more? Okay. So adeno is winning. Squamous has come in. Okay. Yes. It ended up being sarcoidosis. Okay. Sarcoidosis. Now, do I have a 10? Okay. So 10. Take tall woman, severe headaches, visual impairment. Okay. So the neurologist said, go and do CT and come. Okay. And then, so they went to do CT. And this is what we are seeing. Multiple ring enhancing lesions in the brain. Okay. So my people in radiology said metastasis. Okay. So what is the question? The question is that causes of metastasis to the brain. You can choose more than, it doesn't allow for more than one. Oh, sorry. I think if you are in a rush, that's what happens. Okay. So it looks like it doesn't allow for more than one. Okay. But the truth is that all of them can send meds to the brain. All right. So for this particular person, we did a chest CT. Okay. And this is what we got. We had an adeno. Okay, causing. So apparently she had chest CT. I'm sure, a few cups here and there. So, and then eventually, the thing went to the brain. It was the brain that actually brought her to hospital. All right. So basically, these are the things. All the images from 1 to 10 are MDT cases. Okay. And like I said, I didn't see small cell carcinoma. Okay. Small cell lung cancer. Sorry. Okay. So the small cell lung cancers, are very aggressive lung cancers. They spread easily. They'll go to mediastinum, if you can see. Go to mediastinum, enter the vessel early, get lymph nodes, and they are always on the move. Okay, very aggressive. But the way they behave, also you can hit them easily with chemo, Unfortunately, they recur easily as well. Okay, so you can push them into remission very fast because because of their behavior, but apparently they recur. As a radiologist, let me be in my corner and not go and say things, but they are very aggressive. Okay, so if you see an aggressive tumor going up and down like that, then you need to be careful. Okay, so Dr. Gbadamosi also mentioned using PET, in the management of lung cancer. So here, fortunately, they are all lighting up. You can see this FDG avid areas, here. Okay. But if you had a big lesion and only some parts light up, then if you have to biopsy, then you go for that side. Okay. You go for that side. There are times that you see the CT picture, your clinical story, do not match, so then you go in for PET, so that we can now go for where we think the disease is most likely to be, so that we can get an answer, and then also, as Dr. Gbadamosi said, when you treat the person and there's still some changes, in the lung, you want to do PET to be sure if, and then this is also showing us a lymphoma. Okay, this person had Hodgkin's lymphoma. and you can see this mass here. You can see some lymph nodes around here as well. Okay. So I think that is it. Thank you for your attention. I'll hand over to Center for further listening. Thank you all.
So this, yes, we are here. This indeed has been a radiology masterclass. And this is chest radiology within how many? 2 hours. I am sure the comments would come in to tell us how beneficial this has been. Prof, we want to thank you for the interactive session. Indeed, I've seen many more participation from our audience. This has been very wonderful. I have learned a lot, and I'm sure our audience have really learned a lot. I don't want us to miss sight of the fact that we want you, our suppliers in quote, to pick up these lesions and draw our attention as soon as is possible. We want to ensure that patients do not have to go through a very tortuous referral pathway and end up with a very advanced disease. From what we have seen, I think it's heartbreaking. Almost every image shown shows a very large mass, and almost all of them in stage 4. So with this session, I know very well that we are going to be able to see small lesions, in fact, pulmonary nodules, and diagnose them before they get advanced. And this would be to the betterment of our patient. We are thankful. AstraZeneca, thank you so much for walking the journey with us, helping non-oncologists appreciate what lung cancer looks like. And it tells the story that not every abnormal chest X-ray is tuberculosis. Please, let's have that at the back of our minds. And we are most grateful. I think we welcome questions. Please, we have a short time for questions for our seasoned consultants. You can type in your questions, or we can give some 10 minutes for people to actually speak, raise their hands, and then ask questions. I think that would help. Julia, is that welcome?
So I think this link is not enabled for them to be able to unmute, but they can type in the Q&A chat. I think we have a few questions in there.
All right. So please, let's type our questions in, and then we can get answers for you. Thank you for hanging in there. Julia, are you seeing any questions at your end?
Yes, Prof. We've got some questions.
Please, you can read them, please.
Okay, cool. I think the first question I'm seeing is, when should a primary care physician consider requesting a chest CT scan, and what preparation or referral pathway is appropriate in the Ghanaian context?
Okay, Professor Yao Mensah, and then Dr. Badamoshi would also come in.
Little cautious in this my answer. Okay, so the scenario is this: how long has this person presented with symptoms? You know that a lot of people, when you have, let's say, a regular pneumonia, or let's say upper respiratory tract infection, worst case, 2 weeks, they should be free. So if you see somebody who has come with 6 months, cough and all that, and you do chest X-ray, and let's say you are not seeing anything, or you even think or this antibiotic is from India, so it's not working. So that is when you go on to go and do CT scan, you know, so that we can see better. Because like Dr. Badamosi said, there are so many things that are in the CT scan that you see on CT scan that you won't find on X-ray. So I think I'll pause here and then let her come since she's the expert in that field. Dr. Badamosi.
Okay, so I think that as we speak, her hands are busy on a biopsy
Okay.
table. So yes, so you may, if I get what you are saying, that there can't be one answer to when you should request a CT. One, I guess, if you, from what Dr. Prof. Mensah was saying, if you have a patient who has long-standing symptoms, particularly respiratory symptoms, and you do a chest X-ray and you don't see anything, what you were saying is that at that point, they can request for a chest CT. Is that it?
Yes. I mean, if it's been going on, you don't sit on it so that we can see what is actually happening. Yes. Thank you.
Okay. All right. So that is a fair one. The other thing is that if you also find, like we have described, a nodule, it's what looks like a mass-like lesion, please, you have the liberty to refer to ask for a chest CT. There's one thing that happens in the Ghanaian context. Sometimes when you give a patient a referral and a request to go and do a CT, and they think that it is expensive, they go sitting and trying to gather funds to come and do the CT. And maybe by the time they do the CT, things may have gone out of hand. So we also don't want you to lose sight of the fact that we are not saying always refer with a CT. No. If you see something suspicious on a chest X-ray, and it is suspicious enough, it does, and the patient has symptoms, you can request the CT and refer at the same time. Or you can also give a referral, and then the rest will be carried out as it should be, because most patients disappear when expensive requests are given to them. Thank you. I think there was a part of the question that wanted to know about referral.
Yes, please, Prof. Basically, a few questions are asking about the current referral pathway. So basically, there's another question that kind of ties in and is asking, what suspicious lung, what is the current pathway for referring a patient with a suspicious lung?
Hello, Julia, we lost you.
From the primary care to a specialist center? Do you go to radiologist first, pulmonologist, or?
Oh, it's rather me. Can I be heard? Hello?
Hello, Prof. Please, was that clear?
Yes, we lost you. Yes, it's clear. So many people are asking for referral pathways.
Yes, so the thing is, if you see a suspicious lesion, where do you go next? Do you see the radiologist, or do you go to the pulmonologist or the oncologist?
Yes, so please, you need to come to the pulmonologist. We are pleading with our colleagues out there, refer the cases, because you see, some also refer directly to the radiologist. And in fact, a few people end up at the oncologist. Now, at the oncologist, the waiting time is so long. So your patient is there waiting to be called. If you refer to the radiologist, some of them also get lost in the fray, especially when the appointment list is long. But if you refer to the pulmonologist has 2 weeks waiting period. Is what we are doing now. Any suspicious lesion, we will not keep you waiting for more than 2 weeks. You will be seen. And secondly, you would be recorded and discussed in the MDT, and the appropriate investigation will be done for you. You may think that, oh, this patient can be biopsied by the radiologist, but that might be the wrong route. Sometimes they may benefit more from maybe a bronchoscopy. Sometimes too, if you refer straight to the bronchoscopy suite, they may benefit best from the CT-guided biopsy. So we will plead that the best route for referral, as it is done everywhere, is to refer to the respiratory clinic. And we will put up some numbers on the screen which you can all save, so that if you have such a referral, call those numbers, and then within 2 weeks, patients will be seen. If further investigations are needed, we'll be able to do that. It is best because at the MDT, we know when the surgeon should come in, we know when the
have multiple lesions that will be primary plus mets, or multiple lesions that will be all mets, But I think that knowing the patient, for instance, if we know that the patient has had colonic surgery, for instance, or the patient has some symptoms that point, let's say this are woman who we knew has had breast, surgery, for instance, then we know that then this one is likely to push us more towards metastasis than primary, But often if we have a primary plus meds around, you see that the primary will be a little bigger and a little bit more suspicious, speculated margins and things like that. And you may have regional lymph nodes nearby and all that, showing the prominence or the dominance of that one. And then you have meds nearby. So this is what I can say for now. We usually will know the story, want to know the story about the patient, before we can now conclude whether we favor meds or we favor, primary. Thank you.
Okay, thank you very much, Prof, for that. Yes, Julia, back to you. Any questions?
Yes, so Prof, one question that has pulled through was how we can improve communication between primary care and the specialist centers. I think the numbers that you were mentioning will help, but maybe I'll just throw it to you.
Yes, so when it comes to referral for inpatient, I think there are some numbers that are of our emergencies around which people complain doesn't work. But when it comes to OPD referrals, I think that is where the issue is. There are supposed to be numbers that work, but often people can't get through unless patients walk physically here to get booked at the medical OPD department. But I think that to help bridge the gap, very soon we'll have maybe callable OPD numbers that are working and can serve our colleagues. But I think for now, what we are trying to do in respiratory is to get we have our clinic reps numbers, and we hope to, we are sharing that with you so that you can easily assess those ones as far as respiratory referrals are concerned, so that we don't keep our patients hanging out there for too long, especially with lung cancer. Thank you. I'll share with you, Julia, then you can put up on the page, okay?
Yes, please, Prof. So another question is, how can a primary care physician support patient counseling when imaging results are inconclusive or delayed? It's like basically, what do you tell the patient when you're not sure what you're seeing or we don't have any information?
Okay, Prof. Yalbi, please.
No, I don't understand the question. Julia, how do you understand the question? Maybe if you tell me how you understand the question, then
Okay, so how I'm understanding the question is you're seeing something suspicious on maybe a radiograph or CT, and you're not sure what it is. What do you tell the patient? How do you go about counseling the patient about what you think in your clinical opinion? Yes, please.
Okay. So let me start from Prof. Ifuye Mensah's initial comment. Don't sit on the case. Do you get? So my mind is don't sit on the case. My answer I'm giving is don't sit on the case. All right. But having said that, I mean, even in quotes, my residents, they always get WhatsApp pictures from colleagues. Charlie, what do you think? What do you think? What do you think? You get it? Some bring the films to us. Some bring the CDs to us for us to discuss. All right. So if you are seeing something at a primary care area and you are not sure, okay, if you are fortunate, don't use daylight. If you have view box, you see, put it on a view box, turn off your flash, take a picture, and send a WhatsApp to any of your male friends or female friends who are in the radiology department. We'll take a look, we'll ask you questions, and then we'll advise accordingly. All right, don't keep the patient because you are not sure. If you have a CD or something and you are not sure, or you don't even agree to what the doctor is saying, call somebody, one of us somewhere, you know, and then send relative with a CD. We'll look at it, and then now my new style of communicating is voice note. I look at it and then I'll give you a voice note of what I feel, because at times when I say I'm calling you, I'll forget. So I'll send you a voice note of what I think, and then, you know, the patient will be good to go. All right. Failing all this, you can just write that you want a report on the image, you know, whilst you're also thinking of referring to pulmonology. You get it? So quickly refer to pulmonology, you know, and then, you know, or even let them call pulmonology so that they can have a discussion with you, you know, whilst we try to resolve the imaging findings that you're not sure about. Thank you. I hope I've answered it. I mean, it's clear.
Yeah,
This
is very clear. And I hope our listeners have also got the clarity of it. Okay. So, Julia, we do have, you can put the numbers up in the chat box so that our colleagues, special colleagues out there can have it and make calls whenever they...
Yes, please. Prof, please, I've put it up.
Okay.
I've put it up, and this is a suggestion from an attendee saying that if we could have a WhatsApp or Telegram group where we can put up X-rays or radiographs to get feedback, to avoid the back and forth. I'm not sure. I don't know if this is possible, but it looks like this will ease.
This one, let me talk to. Let me leave it to Prof. He probably will crash his work out. He won't be able to work. So let me leave it to him.
You see, so that's how there's a way of reaching us. By all means, you have classmates in radiology. You see, by all means, you have classmates in radiology. So I beg, just try and send it to your classmate who now, if they are not sure, you'll be there. They come to your office and say, hey, this one, the physicians are saying this, so you get it. So by all means, look, I have somebody who was a house officer in Tamale, you know, and said that he has a friend who was in UGMS. That the person I'm speaking to is a graduate of UDS, but has a colleague who recommended me. He doesn't know me from anywhere. House officer called me, you know, sent me images. I called him back. We discussed it, and he was happy. You get it? So they don't need to know me, or, you know, they can just find a way of reaching me. Introduce yourself, send it to me, and then we'll do, or send it to one of my, you know, residents. They'll find me, and then we'll take it from there. You know, Prof J, I've sent you a WhatsApp.
Yes, please.
Have you seen that WhatsApp?
Yes, you
Okay,
have.
there's a question by it. I'm going to send a question.
Oh, okay, okay. So let me just give a brief. Like I said earlier, we will soon be coming to you with some form of screening protocol. What we have seen is that most patients with pulmonary nodules on CT are just left to go like that. Sometimes you may ask them to go and do a CT and they say, oh, there's a pulmonary nodule here. That was not your intended plan. It may have been an incidental finding. Ideally, there are what we call pulmonary nodule protocols, where patients with nodules are followed up. And aside the presence of the nodule, there's also the clinical aspect where you look at certain clinical risk factors and know what you have to do about that nodule. But in our space, we haven't really done that. We've left that space open. And we always say that a lung cancer develops as a nodule. So we will soon be coming to your various stations where you are with this pulmonary nodule surveillance initiative, so that when you see a case, see an image that has a pulmonary nodule, maybe it's incidental, you're seeing something else, there will be some number for you to call and initiate that person through a certain pathway. Then they can be followed up, and the nodule carefully followed up by Professor Yaubi and his team. And the clinical assessment and risk model tools would also be assessed, and we know whether that is high risk or not and how to manage that case. So thank you, Professor Yaubi, for raising that. It's something that we've worked on and very passionate about. So we will get to you soon and let various outlets know the numbers to reach when they have the pulmonary nodule. For now, I think you can still reach the numbers we have given you if you have identified a patient with an incidental pulmonary nodule. Thank you for that. Professor Yaubi, does that suffice for now?
Yes, I think so. I think so. The
Yes,
other thing that we are also thinking about is sputum negative TB, isn't it?
Yes, please.
That one will reach you with some protocol. We want to see, or, you know, make sure that sputum negative is not equal to lung cancer, you know. So we'll reach you, you know, and get this message across as well. Thank you.
Thank you very much. Julia, please, is it okay at your end?
Yes, Prof. It's okay. I think in the interest of time, we have to round up.
We have to wind down.
Yes.
Okay, okay. All right. So, well, I would also be handing over to Julia soon. I would first want to thank all our online participants. It's been a wonderful session, very educative, very instructive. We thank Professor Yaubi, we thank Dr. Hafi for the instructive case presentation they have given us this afternoon to evening. I am very sure that we all have had some, how do I say it? We've dropped the fears about chest x-rays. When we see them, we will be able to look at it and make some informed decisions to help our patients. Thank you very much. And with this, I wish you all the very best. Please, we are not too far away. Reach us anytime, especially on the numbers we have given, if you have cases you want to refer to us. Thank you. Julia, over to you.
Thank you so much, Prof. And I'll say a big thank you to all the participants on the call and for spending your afternoon basically or your evening basically with us. And I think that I've learned so much from this session. And we hope that these little nuggets of information will help us improve care to all our patients and, boost early diagnosis and heighten our sense of awareness around lung cancer. So I have dropped a link inside the chat for you to access the CES site to claim your points, as well as the numbers for the reps for the chest clinic. So with that, I will just say a big thank you to you all, and please do have a good evening.
Bye-bye. Thank you, Professor Yalbi. Thank you, Hafi. Bye.
Bye-bye, bye-bye, bye-bye.